Okay, so I'm Ranj. Thanks for joining us. We wanted to talk about the angio-OCT angioplex and why it's so useful for our practice. Thanks for Raluca and Kevin at ZEISS for organizing this. It's really useful at this time to be talking and discussing about cases. So here's my disclaimer. And we really want to talk about the use of angio-OCT in retinal vascular disease here, particularly talking about diabetes, proliferative diabetic retinopathy, macular ischemia, peripheral ischemia. Why is it important for us to document that? Diabetic macular edema, and why it's important to do an angio-OCT in patients we're considering treatment with, retinal vein occlusions, and then other things. So we'll just talk through it. I think it's really important for patients to get a very good image. I think the better it is, the more understanding of their condition and the more on board they are, which, over the long term, which they'll be with you for. And then for us, we want imaging and show patients whether things are progressing, what their response to treatment is. So here's a patient with diabetes, typically we see with the Claris. And it's a good record. We some time ago would have done a fluorescein, but we can see some details here, some vascular abnormalities, cotton wool spots and such. And with the angio-OCT, we can do a montage. That takes us out pretty wide to the mid-periphery arcades. We can see some capillary dropout, some vascular abnormalities. And the good thing about the angio-OCT is we can repeat it at regular visits. And we compare it with a fluorescein. You can see similar features, the mid-peripheral ischemia, vascular abnormalities, but the fluorescein is something patients just want you to do the once, not repeated, whereas with the angio-OCT, we can repeat it and monitor. So the other things to look at are proliferative diabetic retinopathy. This is always a question for us. When do the new vessels start? Are they new vessels? How long have they been there? Are they regressing? Are they progressing? So really important for us to document. With the angio-OCT, we get depth-encoded images, so superficial, deep, and avascular zones. And we can just make out there's some redness in the superficial area at the edge of the disc. So it's important for us to know, is that the start of something? When we switch to the vitreoretinal interface, we can clearly see this is automated on the angioplex, a tuft that looks suspicious there at the edge of the disc. So as we scroll through it on the B scan, you can see a tuft of new vessels at the edge of the disc. And as we come through it again here, you'll see, and it's got some flow in it, which is an abnormality. Any blood vessel with flow above there is abnormal. So that's an early new vessel. And it's important for us to document that so that we can look at them when the patient comes next time and compare if there's any change in them. And there's the vessel. This is a more advanced new vessels. There's a lot going on here, and there's some papillitis in a young patient. We can see, as I said, more abnormalities there, so some capillary abnormalities, some new vessels possibly. This is depth encoded and a really beautiful image. As we look at the B scan, we see the papillitis and these engorged vessels. But there are some new vessels across the cup there. You can see them with the flow. And then there's a neovascular membrane coming down. So, this is really important to document because we need to start treatment for this patient. It can happen in some of these patients that they're asymptomatic until they have an event. So we really need to show them what their image is and document that before we start treatment and then as we go along. New vessels elsewhere. So here we see an area of capillary dropout, ischemia, and adjacent to that, some new vessels, tuft there. So again, we document it. We've got the B scan here. If we scroll through, we can see the thinning of the retina where there's capillary dropout. And then as we come through the new vessels, we can see flow above the retina. So that's a neovascular frond of new vessels. So we've documented that. We can monitor and see how they respond to therapy. Again, some new vessels we can see on the depth encoded image. As we scroll through it, we can see a neovascular membrane just above the retina with some flow in it. So again, very important to document this. We can do this really accurately without going to fluorescein angiography. And we need to remember, actually, fluorescein can cause leakage from these new vessels, and that can interfere with our ability to deliver PRP. So this is a really good way to document neovascularization. So as we said, documentation is essential for us, for the patient, We want to look at stability versus progression. You know, we don't automatically laser all new vessels. I showed you a very small new vessel at the edge of the disc. There are, based on the DRS rationale to treat. So once we reach certain stages, we can discuss that with the patient and say, look, you were like this last year. HbA1c is not quite so good and it's progressed. We really need to start getting on with treatment. And so we can do that. You know, angio-CT, as I said, is repeatable. So we can repeat it at every visit. Here we can see just at the center here is a small new vessel. And then we just document that carefully. We can see it on the B scan. And then we look at them about 3 months later. It's exactly the same. It's a small new vessel. We don't need to intervene yet. We do need to monitor that. So we can flag that up for a similar angio-CT at the next visit. So that's a really nice way to compare. Diabetic macular edema, as I said, we're treating that more with anti-VEGF, and we need to just have a look at the vascular state of the retina before we start treatment. So here's some intraretinal cysts and fluid. Do we treat them, you know, based on a structural OCT? Yeah, possibly. We know anti-VEGF is a good treatment. But when we look at the angio-CT, there's a lot more to the story. You know, there's some central macular ischemia, some a little bit further out. And so this will affect the retinal function. You know, it's important to tell patients these sorts of details because then their expectation is realistic. You know, not all patients gain X letters. And these are long courses of treatment for years. And so we need to be on board at the beginning. If they're not seeing a good response, they may be disappointed. Whereas if you can frame it well early on with angio-CT images, then that's very useful. Here we can see a map, a fusion map, density of both eyes, and we can see the capillary dropout, the irregular FAS. And just showing these to a patient, they know what a normal retina looks like, and they know that this is not quite normal, and they'll become familiar with these images. As I said, we can repeat them sequentially, and we see them for a long time. If we scroll through, we can see very thin retina there, temporally where there's ischemia, and then at the center as well. Here's another case, intraretinal fluid, cystic. There is some RPE disturbance. This was an older patient, so we considered whether to treat them, and we decided to go ahead with some anti-VEGF injections for them. This is on the left prior to treatment. And then as we look at the image there, we can see that they did respond well. The edema has reduced. There is some RPE disturbance. And if you look closely, you can see that's a sort of a PED that maybe have a vascular element. So we looked at the angio-CT. We can see an abnormal vessel here. Again, depth encoded, we can see superficial to deep, and the vascular area in that little tuft there that you can see at the edge of the FAS. You can see that there's a vessel that's red, it goes green, and then there's a component of it that's blue. We zoom in on it there. So that's the same vessel that's tracking down through the retina. And then we see it on the avascular slice, this abnormal vessel. If you look at the PED when it comes through, the vessel has dipped down into the retina, and you'll see there's some flow across that as well. Here we go. So if we look at the flow there, we can see there's flow coming down through the retina and to the RPE. And here we see it. So that's a, you know, diabetic patient who's elderly. That can happen for sure. They've got some RPE disturbance, but they've had a RAP lesion develop over time. So it's important to discuss that there could be co-pathology going on with this patient. Retinal vein occlusion. Here's a large amount of edema. Certainly anti-VEGF is a good option. If we look at the angio-CT, we can see that it's an inferior hemiretinal vein occlusion, and there's significant ischemia coming up towards the macula. So it's important, again, to discuss treatment options with the patient, and that they will need regular monitoring and manage what they expect from this course of treatment. Here we look at the angio-CT, we can see that increased capillary spacing and ischemia. Here's a patient who was pregnant, a young lady who had a branch retinal vein occlusion. You know, we are cautious with investigations and treatment. So we didn't want to do a fluorescein. Patient didn't want to have a fluorescein, understandably. And with the angio-CT, we're clearly able to show the degree of superior ischemia there. And when there's ischemia, we worry about, adjacent to that, could there be neovascularization? So we perform the angio-CT. You can see as we scroll through the ischemic retina, and then at the junction, there's a new vessel that's grown up there. So that's important. You know, we were able to document that. We didn't need to do a fluorescein, and we can get on with performing laser treatment to prevent that getting worse, you know, as vascularization can progress in pregnancy. There's the vessel dipping down. Next case is a retinal artery macroaneurysm. You can see it on the on FAST and on the angio-CT there. And if we look on the left side of the screen, the structural OCT shows us that there's some fluid there. The angio-CT shows us the aneurysm, and the depth encoded image also shows us that. So if we scroll through it, we can see the vessels superficially lying with a good amount of flow there through it. So that's a angio-CT, and we can see the fluid in the retina and subretinal. So very important for documentation. You may go ahead and offer some treatment for this patient, and we want to look at how that changes with time. Here's the large aneurysm in a E-scan section. Other things that we find useful, this is the CARAS image, and you know, we really benefited from this in terms of patients being able to document the degree of sickle cell retinopathy and then to look at them sequentially for change. So that's the service we've developed, thankfully, with the really nice technology of the CARAS from ZEISS and the angio-CT. We're able to offer a new screening program here at Moorfields. So it's very important to have that discussion with patients about sickle cell and how it can affect the retina. You know, even if we're not going to offer intervention, it's still important. Here we can see on the angio-CT, we've got an irregular FAS enlarged, and so that may affect the vision. If we look at the angioplex superficial slice and the B scan, we can see that temporarily there's thinning of the retina. So although this patient may not be having problems with their vision, we can discuss this with them and their hematologist. So they're the hematologist, the patients, and we have been really pleased that with ZEISS we've been able to offer this screening service with this quality imaging. So those are the main cases that we wanted to talk about. I hope you know, you will have a think about why we really think it's so important for patients to be able to document things, and for us. So these are a few of the things we wanted to say, really. I think it engages patients well so that they can understand their diabetic retinopathy, where they are, whether there's progression, and why that might trigger a rationale for some treatment. As I said before, you know, some of these patients may be asymptomatic till late on. So it's very important for them to understand why we're saying we want to do this intervention, which may be prophylactic in nature, so may not help them immediately. And then it allows us to document what stage they're at so that we can monitor them in the clinic, and progression so that we can talk about rationale for treatment. OCT angiography in macular edema, whether it's DMO or retinal vein occlusion, forgive me, DME or retinal vein occlusion. Why is that important? Well, you know, it's a vascular disease, so we need to look at the capillaries, document whether there is macular ischemia, which may affect outcomes, and have that discussion with the patient. Not all vein occlusions or macular edema are the same, and it helps us feel confident. You know, macular edema can be a pathology that comes out of a number of diseases, so it helps us really identify in that case that we saw there. So thanks very much to Kevin and Raluca for allowing me to talk. As I said, it really helps at this time for us to be able to discuss these cases, and hopefully we can discuss it some more.